Let's pick up our discussion of the neck with the venous and lymphatic drainage of the neck. So the veins again are formed after the capillaries have distributed the plasma and its nutrients into the interstitium, drains the blood, while the lymphatic drainage would be a series of nodes and lymphatic vessels that drain lymph or the lymphatic fluid, which is an ultrafiltrate of the plasma. So the first structure that you would have to appreciate for the venous drainage of the neck would be the external jugular vein. This picture is great because it shows you the relative anatomy of the external jugular vein. So the external jugular vein would drain the more superficial structures of the head and the neck. First, you have to appreciate that the external jugular vein, which is this structure in the pointer, is situated superficial to the sternocleidomastoid. It is also situated on the belly of the sternocleidomastoid, superficial to the transverse cervical nerves, which provide sensory innervation to the anterolateral skin and structures of the neck. The external jugular vein is formed by the fusion of the posterior branch of the retromandibular vein, which is this one, and the posterior auricular vein. The posterior auricular vein drains the posterolateral aspect of the scalp just behind the ear, whereas the retromandibular vein would be the vein that you will find at the angle of the mandible. Here you have a unique anatomy because the retromandibular vein will actually have also an anterior branch, which is this one, and connects to the facial vein, which drains the face as it empties into the internal jugular vein. So the system, which is the retromandibular vein system, will connect the internal jugular vein and the external jugular vein via the anterior and the posterior retromandibular veins. You will also observe here that the posterior auricular vein is deep to the great auricular nerve, which supplies sensory neurons to the ear and the posterior lateral aspect of the ear. The external jugular vein, again, is superficial to the sternocleidomastoid, whereas the internal jugular vein, which is contained in the carotid sheath, is deep to the sternocleidomastoid. This has important implications when you are going to perform your catheterization of the internal jugular vein. The landmark will be the sternocleidomastoid muscle. Next, this picture will show you the anatomy of the internal jugular vein. So the internal jugular vein will drain the deeper structures of the head and the neck. Let's start at where the internal jugular vein drains into the left brachiocephalic vein. The left brachiocephalic vein is formed at the fusion of the internal jugular vein and the left subclavian vein. So you are looking at this at the left lateral view. Here is the internal jugular vein, and you will appreciate that it will occupy a deep position in the neck, and it continues superiorly to become the sigmoid sinus of the brain, which drains the transverse sinus and the cavernous sinus. So the sigmoid sinus, which is this one, will continue inferiorly as it passes through the jugular foramen to become the internal jugular vein. Okay, so let's appreciate the tributaries of the internal jugular vein. from inferior to superior. The first tributary would be the inferior thyroid vein, which is this one. Next, the middle thyroid vein. And lastly, the superior thyroideal vein. Here, the facial vein, which drains the face, also drains into the internal jugular vein. But you have to remember again that there is a connection between the facial vein and the posterior auricular vein, and that is the anterior division of the retromandibular vein. You will also see here the pterygoid plexus, which is a network-like structure of veins that drain the pharynx. So the pterygoid plexus fuses to become the maxillary vein, which eventually drains into the facial vein and then into the internal jugular vein. On this picture, you will also appreciate that the facial vein will actually have communication with a deep vein of the brain, which is the cavernous sinus, and that communication would be the ophthalmic vein. So this is the ophthalmic vein. Therefore, infection here in the face, if it seeds into the facial vein, can actually go retrograde and enter the cavernous sinus, where you will have cavernous sinus infectious thrombosis. And that is a deep-seated infection of the brain from an infection of the face. You will also appreciate on this picture the position of your superficial temporal vein, which occupies the temporal region of the skull and drains the scalp as well as the cortical bone of the skull. And when we combine those structures together, this is what we will see. This would be the complex vasculature of the head and the neck. In particular, showing to you the relative superficial location of the vein compared to the artery. And again, our landmark for the great vessels of the neck would be the sternocleidomastoid. You can think of the sternocleidomastoid as a muscle that protects the more important structures, the vasculature and the viscera of the neck. Here, you will also find that the scalenus group of muscles will actually sandwich the great vessels of the neck, okay, between the sternocleidomastoid and the scalenus group of muscles. As a summary, superficially, the head and the neck is drained by the external jugular vein, whereas the deep structures of the head, including the brain, is drained by the internal jugular vein. The external jugular vein is formed by the fusion of the posterior branch of the retromandibular vein and the posterior auricular vein, whereas the origin of the internal jugular vein on the jugular foramen on the base of the skull would be from the sigmoid sinus, which drains the cerebral veins located on the dura covering of the brain. Next, these yellow structures that you will see here would be the lymphatic system of the head and the neck. In particular, the yellow ovoid structure, such as this one or this one, would be the nodes. And you will observe here that the lymph nodes are connected to each other via lymphatic efferent vessels. So these yellow squiggly lines right here would be the lymphatic efferent vessels. The lymphatic system is there to reabsorb the excess interstitial fluid. And whenever there is a pathologic process, for example, an infection, that interstitial fluid will be filled with debris, and it will be filled with bacteria and even white blood cells. Those inflammatory fluid will be drained and progressively filtered by the lymphatic system. Why? Because the lymph nodes are actually collections of white blood cells, in particular macrophages and lymphocytes, which will continuously phagocytose the debris and clean the efferent fluid. So you will observe from this picture that you have a series of lymph nodes, okay, and lymphatic ductular systems. So much like the flow of blood in the veins, the flow of lymph in the head and the neck will also follow a systematic pattern. It will start from the head and drain progressively downwards, and it will also start from superficial and drain progressively into deep. So again, the drainage of the lymphatic vessels would be from superior and superficial to deep and inferior. So let's just take a particular look at the labeled lymph nodes. You have to understand that these are highly variable. Okay, the anatomy of the lymphatic vessels are highly variable. So first you have your facial nodes, in particular the nasolabial and the buccinator nodes. This will be drained into the mandibular nodes, which are lateral to the mandible. So you have one here and another here. Then these nodes will be drained by the submandibular nodes right here. And these submandibular nodes will drain progressively further into the superficial nodes and then into the superior, deep, lateral cervical nodes, which will abut the internal jugular vein. So the effluent here in the superior deep lateral cervical nodes will continue inferiorly into the jugulo-omohyoid node. Again, because you have here the internal jugular vein and the omohyoid muscle, which will insert into the shoulder and originate on the hyoid bone. Okay? After the jugulo-omohyoid node, it will progressively drain into the jugular trunk and eventually into the thoracic duct, which is this one, before it rejoins the venous blood in the systemic circulation. But you will appreciate from this picture that there is a progressive filtration of the lymphatic fluid as it passes through the node system. So, um, based on this picture also, you will appreciate that there are superficial parotid nodes, you have mastoid nodes, and occipital nodes. And these nodes will either, in particular the parotid nodes, they can either drain into the subparotid node, which is this one, and progressively go anterior and midline, or it can drain posteriorly into uh, the posterior triangle, which would be your superior lateral superficial cervical node, sternocleidomastoid node, posterior lateral superficial cervical nodes, your intercalated node, and then your transverse cervical chain of nodes before emptying into the thoracic duct. So in summary, again, the usual pattern of drainage of the lymph node will be from superior to inferior, superficial to deep, and then from lateral to medial. So the superficial nodes are found in close association with the external jugular vein, whereas the deep nodes are found in close association with the internal jugular vein. And you will see right here that this group of lymph nodes, the posterior lateral superficial cervical nodes, are found around the accessory node. So that what can happen is you can have a malignancy, for example, in the throat or in the um, salivary glands, and those malignant cells will be drained by the jugular nodes and the other lymph nodes. And if it does drain into these lymph nodes around the accessory nerve, you will have to sacrifice or remove also the accessory nerve during your oncologic resection of the tumor. So in summary, the drainage would be from the superficial group of lymph nodes to the inferior deep cervical nodes, then to the lateral cervical nodes, supraclavicular nodes, the jugular lymphatic trunks, the thoracic duct, and then into the venous angle, where the lymphatic fluid is returned into the systemic circulation. Now let's discuss the organs that are found in the neck, or the viscera of the neck. The viscera of the neck are disposed into three layers, arranged from superficial to deep. So that means that the organs are found on top of each other as layers. The first layer, anteriorly and superficial, is the endocrine layer, or the group of organs that produce hormones. These are the thyroid and the parathyroid glands. The thyroid gland produces the thyroid hormones, triiodothyronine and tetraiodothyronine or thyroxine. And those hormones are important for metabolism. Whereas the parathyroid glands are located posterolateral to the capsule of the thyroid gland, and these glands produce the hormone, parathyroid hormone, which mobilizes the calcium in the bones. Next, posterior or deep to the endocrine layer would be the respiratory layer. And these sets of organs are important for conducting inspired and expired air. So, the first organ, which will be the focus of our discussion, would be the larynx or the voice box. And the larynx is connected inferiorly to the trachea. The larynx or the voice box is made up of mucosa, a cartilaginous skeleton, and a group of muscles which move the skeleton, and in so doing produce the different sounds for phonation and talking. Deep to the respiratory layer would be the alimentary layer, or the gastrointestinal tract. And in particular, the focus of our discussion would be the throat or the pharynx. The thyroid gland originates as an outpouching of the tongue, in particular the pharyngeal arc, and it descends posteriorly of the tongue through the foramen cecum. So you can imagine that the thyroid gland, when you were still an embryo, was located adjacent to the tongue. But as you develop, the thyroid gland actually descended from the mouth into its position in the neck. The thyroid gland is composed of two lobes connected by an isthmus. So there is a left lobe and a right lobe, and then there is a bridge connecting the two lobes, and that is what you call the isthmus. And the total weight of the thyroid gland can vary from 25 to 35 grams. More than that, it will be considered an enlarged thyroid gland, or otherwise known as a goiter. That is important because the endocrine layer of the viscera is on top of the respiratory layer. So, if you have a very large thyroid gland, for example, a goiter, that can impinge or squeeze the respiratory layer and produce difficulty of breathing. Based on its vascular supply, the thyroid gland has two arteries on the left, two arteries on the right, three veins on the left, and three veins on the right. Now, for the parathyroid glands, there are between 4 to 6 parathyroid glands, but the most common number would be 4. What's unique about the parathyroid glands is that they are closely located to the thyroid gland, in particular on the posterolateral aspect of the two lobes of the thyroid gland. Two are found superiorly and two are found inferiorly. So that during surgery for the thyroid gland, for example, removal of the thyroid gland, uh, it is not an uncommon scenario that the parathyroid glands would also be removed. So, as much as possible, you would like to preserve the parathyroid glands and remove only the thyroid gland. But if the parathyroid glands are removed, what will happen is there will be low levels of parathyroid hormone, and that will lead to hypocalcemia or low levels of calcium in the blood. What's also unique about the parathyroid glands is that the superior parathyroid glands have a different origin than the inferior parathyroid glands. Okay? The inferior parathyroid glands actually originate from the pharyngeal arc, and they descend, much like the thyroid gland, into the inferior portion of the thyroid gland. Because of that descent, what's unique is that there can be um, a variable location of the parathyroid gland, and this is what we call an ectopic gland, a gland that is abnormally located, and it can be found even in the mediastinum, which is the central portion of the thoracic cavity. This picture will show you the complex architecture of the neck, in particular the endocrine layer. So, in general, you have here the thyroid gland, and it is called the thyroid gland because thyroid in Greek means shield, and the thyroid gland is shield like in configuration. So, this is your right lobe, and then this is your left lobe, and the right and the left lobe are connected by an isthmus, which is this one. Sometimes, occurring in 1 to 2 out of 10 patients, there can be a pyramidal lobe. which is an extension of the isthmus or the lobe of the thyroid gland. It ascends superiorly and even can rest on the lamina of the thyroid cartilage. So this is the thyroid cartilage of the larynx. The thyroid gland can be found at the level of the superior cricoid up to 3 to 4 tracheal rings. Okay, so at the level of the cricoid up to the fourth uh, tracheal ring, which is this one. Okay, so based on the relative anatomy, you will observe that the thyroid gland sits atop of the larynx and the trachea. Okay, and it is found medial to the great vessels of the neck enclosed in the carotid sheath. So this would be the great vessels of the neck. You have the carotid artery, the internal jugular vein, and in the divide between the two, you will have the vagus nerve, which is this one. So medial to that bundle would be the lateral lobe, lateral aspect of the lobe of the thyroid gland. Okay, let's now go into uh, the pedicles. Okay, so the pedicles would be a collection of structures that enter the thyroid gland. So first, you have the superior pedicle, which is this one, and it is composed of the superior thyroid artery, which is a branch of the internal carotid artery. Okay, and you have also here the superior thyroid vein, which drains into the internal jugular vein. Next, you have the second pedicle, which is just made up of veins. That would be the middle thyroid vein, okay, which drains into the internal jugular vein. The next pedicle would be um, your inferior pedicle, which is made up of an inferior thyroid vein, okay, and posteriorly an inferior thyroid artery. The inferior thyroid vein drains into the brachiocephalic vein, which is this one, and the inferior thyroid artery comes from the thyrocervical trunk of the subclavian artery. Okay, the most important arterial supply would be the inferior thyroid artery. Okay, however, sometimes there can be a variant vascular supply. Sometimes the inferior um, lobe of the thyroid gland together with the isthmus can be supplied by arterial blood by the thyroidea ima artery, which can come from the innominate artery. So that artery can sit right here in the midline and supply the inferior uh, thyroid with its isthmus. What's unique in this picture is that this picture shows you the vagus nerve within the carotid sheath, and as it descends into the chest, it will provide this nerve, which is your recurrent laryngeal nerve, and on the right, the recurrent laryngeal nerve loops here in the innominate artery or the subclavian artery. Okay? Whereas in the left, the vagus nerve descends, and as it descends into the chest, it will give the left recurrent laryngeal nerve, which loops around the arc of the aorta. So that this left recurrent laryngeal nerve would be seen as this one. Okay, and the left recurrent laryngeal nerve would be found in close association between the thyroid gland laterally, the trachea anteriorly, and the esophagus posteriorly. And it will ascend, the recurrent laryngeal nerve will ascend to supply the muscles of the larynx, causing you to produce sounds. So that whenever there is inadvertent injury of the recurrent laryngeal nerve, you will have, even if you're operating on this portion of the neck, you can have difficulty with phonation afterwards if you injure the recurrent laryngeal nerve. This picture will show you the relative surface anatomy of the thyroid gland. So here you will see the close relationship between the carotid artery as it cradles the lateral aspect of the lobe of the thyroid gland, and um, the lobe of the thyroid gland in connection will cradle the trachea and the inferior larynx, and on top of the trachea would particularly be the isthmus. Okay, this is your cricoid or cricoid cartilage, which is a part of the larynx. This would be your right lamina of the thyroid cartilage. This would be the left lamina of the thyroid cartilage, and it will fuse in the midline to produce your laryngeal prominence or Adam's apple in the males. You will also observe that the cupula of the pleura is found close to the inferior pole of the thyroid gland, so that during surgery it is not impossible to puncture the pleura and produce a pneumothorax. This would be the cricothyroid muscle, which is supplied um, for motor control by the external branch of the superior laryngeal nerve, which comes from the vagus nerve, so that during ligation of the superior pedicle for the removal of the thyroid gland, if the ligation is not close to the thyroid gland, the external branch of the superior laryngeal nerve can also be ligated, and that will produce paralysis or paresis of the cricothyroid muscle, producing an inability to produce a high pitch, which is the action of the cricothyroid muscle. Next, this picture will show you the posterior view of the neck, in particular the viscera and the vasculature of the neck. So this structure right here in the middle would be the pharynx, and this would be the cricopharyngeus, which is the most prominent circular muscle of the pharynx and serves as the superior esophageal sphincter. This would be the esophagus, which is the most posterior, and this would be the trachea, which is found anterior to the esophagus. Then this would be the great vessels. First, I want you to note the vasculature. This would be the aorta, and this would be the right innominate artery. The right innominate artery will continue as the subclavian as it goes into the arms, and the carotid as it goes into the neck. Okay? And in between the carotid and the internal jugular vein would be the vagus nerve. So the vagus nerve starts from the base of the skull, continues inferiorly inside the carotid sheath, and then on the right, loops around the subclavian artery, where it will continue superiorly and insert in between the esophagus and the trachea, as well as just close to the divot between the esophagus, the pharynx, and the thyroid gland. Okay. Next, you will appreciate from this view that your inferior thyroid vein, which drains the inferior pole of the thyroid gland and will be very rich in thyroid hormone, will drain into the brachiocephalic vein, as well as here on the right. You will also see here that the second branch of your subclavian artery, which is the thyrocervical trunk, continues and ascends together with the carotid sheath to give branches arterial supply to majority of the thyroid, in particular the inferior pole and posterior surfaces of the thyroid gland. You will also see here from this picture that your external carotid artery, is this one, provides the superior thyroid artery, which is this one, and it supplies the superior pole of the thyroid gland. Your superior thyroid artery, which is this one, also gives a superior laryngeal artery anteriorly. And this right here would be the superior laryngeal nerve. You have an internal branch, which is this one, and an external branch, which goes anteriorly. You have to note that the superior laryngeal nerve comes from also the vagus. And lastly, you can appreciate from this point of view the location of the parathyroid glands. You have two superiorly on each side and two inferiorly on each side. Next, let's go to the respiratory layer. The larynx is the complex organ of voice production, composed of 9 cartilages connected by membranes and ligaments. It is located at the level of the 3rd cervical vertebra up to the 6th cervical vertebra. How does the larynx produce sound? There are muscles that attach to the laryngeal skeleton, and when these muscles contract, they will cause a change in the tension of the vocal folds. So, if the tension in the vocal fold increases, the tightness of the vocal fold increases and the frequency or the pitch of the sound produced increases. It also causes the rima glottidis, or the opening of the laryngeal airway, to close or open. And it also causes the rima vestibuli, which is the opening of the false vocal cords or folds to open or close. All the muscles of the larynx are innervated by the recurrent laryngeal nerve, except the cricothyroid, which is innervated by the external branch of the superior laryngeal nerve. So, the recurrent laryngeal nerve is important because if it is inadvertently injured bilaterally during surgery in the neck, what can happen is that the vocal folds will remain adducted in the midline, and that will close the opening of the airway. But it is really rare for surgery to be performed so that the two lateralities, left and right recurrent laryngeal nerve, will be both injured. The posterior cricoarytenoid is the only laryngeal muscle that keeps the vocal cord abducted and therefore opens the airway. And because this muscle is supplied by the inferior laryngeal artery from the inferior laryngeal nerve from the recurrent laryngeal nerve, injury to the recurrent laryngeal nerve will produce paresis of this muscle, causing an inability to open the airway. That's the posterior cricoarytenoid. This picture will show you the different cartilages that make up the laryngeal skeleton. Okay, so let's first appreciate this anterior view. This would be the hyoid bone, which is a horse-shaped bone found in the superior neck, and this is the only bone that is not attached to any other bone in the body. So, protruding from the superior aspect of the hyoid bone would be the epiglottis. So, the term epi means above and glottis means airway because it is above the airway. And its function would be to open or close um, the airway so that during swallowing of food, no food will come in contact with the airway. Next, you will have here a membrane that connects the hyoid bone to the thyroid cartilage. So this is your thyrohyoid membrane. And this thyrohyoid membrane has a hole anterolaterally, which is how the superior laryngeal artery and nerve penetrates to go into the internal surface of the larynx. Next, you have here the fusion at the midline of the right and the left lamina of the thyroid cartilage, and this is what produces the superior thyroid notch. This is the thyroid lamina, and next you have here the inferior horn of the thyroid cartilage, which is how the thyroid cartilage connects to the most stable of the laryngeal skeleton, the cricoid cartilage. So this is the cricoid cartilage, and inferior to the cricoid cartilage will already be the trachea. So again, the cricoid cartilage attaches to the to the rest of the laryngeal skeleton by the inferior horn of the thyroid cartilage. And next, you also have here a connection between the thyroid cartilage and the cricoid cartilage in the midline, and this is your median cricothyroid ligament, which is punctured to create an emergency surgical airway. For example, if there is obstruction here in the upper airway, a needle can be inserted from the surface of the neck, puncturing the skin and the fascia, puncturing this median cricothyroid ligament to provide an alternative pathway for air to enter um, the respiratory tree. So that procedure is your cricothyroidotomy. Next, let's appreciate the posterior view of the larynx. Here you have the leaf-like structure, which is the epiglottis, and the epiglottis is connected to the internal surface of the thyroid cartilage. Here is your hyoid bone, which keeps intact the epiglottis. Here is your thyrohyoid membrane with its prominent opening anterolaterally. Then this would be the superior horn of the thyroid cartilage. And you have here a thickening that connects the hyoid bone to the thyroid cartilage. So this would be the internal surface of the larynx. And this would be the cricoid. You will appreciate that the cricoid is broader, thicker, and wider posteriorly than it is anteriorly. And what sits on top of the cricoid will be the rest of the laryngeal skeleton. You have here the triangular arytenoid, and you have here the cone-shaped corniculate cartilage. Okay, so on top of the cricoid would be the arytenoid, and on top of the arytenoid would be the corniculate cartilage. You will see here that there is actually a ligament that connects the arytenoid to the lamina of the thyroid cartilage. So this is a ligament called the vocal ligament. And the tension here will dictate how much vibration will be produced by the passing air to produce the different pitches of sound. So the system of cartilages on top of the cricoid would be better appreciated here in the anterosuperior view. This would be the corniculate cartilage, and this would be the two processes of the arytenoid. You have a process where the vocal ligament attaches to, and this is your vocal process. And you have a process posterolaterally where the muscles that will control voice production will attach to. This would be the muscular processes of the arytenoid cartilage. And then this would be the anatomy of the cricoid cartilage. You have an arch anteriorly, you have a lamina posteriorly, and because of this lamina, the cricoid cartilage is classically described as having a signet ring anatomy or appearance. And then you have here the arytenoid articular surface, where the arytenoid attaches to the cricoid. So this picture would show you the laryngeal skeleton with muscles. And what this shows you is that there is actually a mucosa that lines the internal surface of the larynx, such as here where the epiglottis is found. You will also note here that the cartilaginous skeleton underneath the mucosa will produce protrusions on the mucosa. For example, here would be the corniculate tubercle, which corresponds to the protrusion of the corniculate process of the arytenoid. Then you have the cuneiform tubercle, which would be a thickening produced by the ary epiglottic fold. The ary epiglottic fold would be that fold of mucosa that connects the epiglottis to the arytenoid. Next, you have here the oblique arytenoid muscle. So it is slanting in appearance, and it connects the arytenoid uh, with the epiglottis. Okay, and then you have here the transverse arytenoid muscle, which we can appreciate later on in a better view. So this transverse arytenoid muscle would connect the muscular process of the arytenoid with the midline at the level of the cricoid. This is your posterior cricoarytenoid muscle, and it originates here in the broad portion of the cricoid and inserts into the laterally placed muscular process of the arytenoid. You will also see here the foramen in the thyrohyoid membrane as we view the right lateral view. Here is a foramen for the superior laryngeal vessels, and internal branch of the superior laryngeal artery, superior laryngeal nerve, which will provide sensory information on the internal surface of the larynx. The superior laryngeal nerve is important because the sensory innervation is the one that detects the presence of a foreign body in the larynx. So if ever there is a foreign body that obstructs the larynx, this nerve would be irritated and it will cause the start of your coughing reflex in an attempt to clear the obstruction. Here would be the oblique and transverse arytenoid muscles forming a bulge. And then you have here the posterior cricoarytenoid muscle. And lastly, seen here would be the cricothyroid muscle, which connects the thyroid lamina to the cricoid. And when this contracts, it pulls on the thyroid inferiorly to tighten uh, the vocal fold. And that will produce a higher pitch. So this picture will show you um, the anatomy of these muscles in the larynx. Okay, so so far we have discussed the rest except this one. You have here a thyroarytenoid muscle which connects the inferior thyroid lamina to the muscular process of the arytenoid. Okay, you also have here the lateral cricoarytenoid muscle which will connect the superolateral aspect of the cricoid cartilage with the muscular process of the arytenoid. And the muscles that control the tension of the vocal ligament would be best viewed here. First, you have the cricothyroid muscle, which connects the thyroid cartilage with the cricoid inferiorly. So when this contracts, the thyroid cartilage will descend into the cricoid cartilage and it will pull on the vocal ligament, increasing the tension of the vocal ligament. Next, you have the vocalis muscle, which is found lateral to the vocal ligament. And when this muscle contracts, it will cause a shortening of the vocal ligament, decreasing its tension. Next, you have the lateral cricoarytenoid muscle, which when it contracts, it will pull on the muscular process, and that will cause the vocal ligament to adduct into the midline, closing the rima glottidis. Next, you have the posterior cricoarytenoid muscle, which pulls on the muscular process of the arytenoid cartilage, pulling it this way so that the vocal ligament will abduct, move this way. Okay. Next, you have the oblique and transverse arytenoid muscles, which will pull on the arytenoid cartilages together. So this will also lead to adduction of the arytenoid muscles. And here would be the summary of that set of movement. First, the action of the cricothyroid muscle, and the effect will be lengthening of the vocal ligaments, increasing the tension. Next, action of the posterior cricoarytenoid, which will lead to abduction of the vocal ligaments. Abduction. Next, action of the lateral cricoarytenoid muscles, which will cause adduction or movement towards the midline of the vocal ligaments, closing the rima glottidis. Next, the action of the transverse and the oblique arytenoid muscles, which will also lead to adduction of the vocal ligaments as the arytenoids move or glide on top of the cricoid to move closer to each other. Next, you have the action of the vocalis and the thyroarytenoid muscles, which will shorten or relax the vocal ligaments as it is pulled towards the midline of the vocal ligament length. Next, this picture will show you the distribution of the superior laryngeal nerve as it gives the internal branch which goes into the internal surface of the larynx to provide sensory innervation as it penetrates the foramina of the thyrohyoid membrane. Then the external superior laryngeal nerve will continue inferiorly to supply the cricothyroid muscle, which is important for increasing the tension of the vocal ligaments, so that during surgical exploration of this region, for example, during thyroid surgery, this can be severed. This will be paretic, the cricothyroid muscle, and the patient will have an inability to produce a high-pitched sound. Next, you have the cricopharyngeus muscle, which is your inferior pharyngeal constrictor, and it is in close association with the cricoid, as well as the recurrent laryngeal nerve, which supplies uh, all the rest of the muscles of the larynx. The pharynx or throat is a fibromuscular tube that connects the nasal and oral cavities of the head, the nasopharynx and oropharynx in particular, with the larynx. That's the portion of the hypo or laryngopharynx. So it connects the nose, the mouth, with the larynx and the esophagus. It extends from the base of the skull to the cricoid cartilage, where it continues as the esophagus. There are subdivisions of the pharynx based on the more anterior structure. So the portion of the pharynx that is located posterior to the nose would be the nasopharynx, and it ends above the soft palate, which would be the region of origin of the oropharynx. The oropharynx would be the region of the throat or pharynx posterior to the mouth, and the laryngopharynx would be the region of the pharynx posterior to the larynx, and it starts from the tip of the epiglottis to the cricoid cartilage. So in this picture, you will be shown the regions of the pharynx. This would be the nasopharynx. Okay. And in particular, this posterior opening would be the choana of the nasal cavity. So in the choana, you will see here the nasal septum as well as the turbinates or the concha uh, of the nasal cavity. The concha is a collection of bone covered with respiratory mucosa, which serves to filter and humidify the air. This would be the region of the soft palate, and the soft palate will continue posteriorly in the midline as the uvula, and from here to here the root of the epiglottis, that will be the region of the oropharynx, and from here you will see the uvula, the palatine tonsil, as well as the base of the tongue or the root of the tongue. The base of the tongue or the root of the tongue, where it indents into the epiglottis. This region right here would be the piriform fossa. And this portion right here would be the most common site of food or foreign body obstruction in the throat. Next, you have here the epiglottis, And whenever you swallow food, the epiglottis would fold over the aditus or the laryngeal inlet so that food will not reach the airway. And the pharynx, again, will continue inferiorly as the esophagus. And what guards the opening of the esophagus would be the thickening of the cricopharyngeus, which will serve as the superior esophageal sphincter. The pharyngeal constrictors participate in deglutition or swallowing and move the food bolus from the oropharynx to the proximal esophagus. And the functions of these pharyngeal muscles would be in accordance with the physiological principle of the law of the gut, where the proximal portion will contract and the distal portion will relax in order to propel the food bolus. So in another view, this will show you the muscles of the pharynx from the outside. So this is your superior pharyngeal constrictor. This would be the styloglossus, which connects the styloid process to the root of the tongue. This would be the stylopharyngeus, which would connect the styloid process with the cricopharyngeus or the middle constrictors. Okay. Here you have the hyoglossus, which connects the tongue with the hyoid bone, and these are your suprahyoid muscles. And we will continue inferiorly with the inferior pharyngeal constrictor, which is the portion of the pharynx at the hypopharynx. So the inferior pharyngeal constrictor will actually have a thickening or the bulking up of muscles to form the cricopharyngeus, which attaches to the cricoid um, cartilage. And this will serve as the inferior pharyngeal constrictor or the superior esophageal sphincter. And again, the pharynx will continue inferiorly as the esophagus. So what would be the blood supply of the pharynx? You have two main branches, the thyrocervical trunk from the subclavian, in particular the ascending cervical artery. And you have a branch from the external carotid, in particular the superior thyroid, the facial, the ascending pharyngeal artery, and the maxillary artery, the most important of which is the superior thyroid artery. So let's just recap those. This would be the thyrocervical trunk, and this would be the ascending cervical artery. So that will supply the pharynx. And then from the external carotid, which is this one, you have the superior thyroid artery. Then you have here the facial artery. And then you have here the maxillary artery, as well as the ascending pharyngeal artery. What about the innervation or the neuronal supply of the pharynx? The sensation in the pharynx is observed by three nerves: the nasopharynx, sensory innervation from the maxillary nerve or the second branch of the trigeminal nerve, the oropharynx, sensory innervation from the glossopharyngeal nerve, and the hypopharynx, sensory innervation from the vagus nerve. So you will observe that as the portion of the pharynx goes inferiorly, the innervation also proceeds more distally. Maxillary, cranial nerve 5, cranial nerve 9, cranial nerve 10. The muscles of the pharynx are supplied by the veins. And lastly, guarding the pharynx, in particular the oropharynx, would be the Waldeyr's tonsillar ring. It is made out of the tubal tonsils, the pharyngeal tonsils, the palatine tonsils, and the lingual tonsils. So it forms a ring around the opening of the mouth. And these tonsils contain lymphoid tissue, which will be important components of the immunity. It will tell the body what goes into the gastrointestinal tract. This would be the lingual tonsils at the base of the tongue. This would be the palatine tonsil, which is the one that enlarges um, during tonsillitis on inspection. Then you will have here a pharyngeal tonsil, and you have here the tubal tonsil. So together they will form a ring. The tonsil that is associated with the nasopharynx would be the adenoid.